Bismillah ar-Rahman ar-Rahim. Alhamdulillah Rabbil Alameen. Good evening, everybody, and thank you very much for joining us tonight. This is Lasave lecture series from Oman Diabetes Association. This lecture is number 8, and our guest speaker today is Dr. Lalila Al Hashemi. Dr. Lalila is consultant pediatric endocrinologist from Nizwa Hospital, and she is going to talk about monogenic diabetes mellitus. Before starting, we would like to express our gratitude and thanking to Lilly Company for sponsoring this event. And we would like also to thank you us for joining us and remind you to put your all questions in the Q&A section in the Zoom. And we will leave the question maybe at the end of this seminar after the second speaker that we are going to introduce him in due time. So Dr. Lalila, thank you very much for being with us. Dr. Lalila also had some technical issue in opening her camera, but she looks exactly the same as in the lecture, in her picture in the announcement. And as part of our sympathy, also I closed my camera. So Dr. Lalila, you are most welcome, and thank you very much for giving us your time today to teach us about this interesting topic. So the floor is yours.
Thank you very much, Dr. Ahmed, for having me this evening, sponsored by Lilly. Thank you so much for this opportunity. And of course, for Oman Diabetes Association, always supporting us. And again, I really apologize about the technical issues about the camera, but even how we could proceed, inshallah. So it was quite intensive, heavy topic. I tried my best myself to make it a little bit simpler or easy to follow. And the most important thing, how much we could take it on board and how much we could have it in our clinic, in our practice, okay? The outlines will be mainly classification of diabetes in general, so that we will know where to put our hands when we are speaking about monogenic diabetes, just to have this broad map and then into the depth of monogenic diabetes. Most important is when to suspect monogenic diabetes and proceed for genetic testing, and during which I'll have some few cases to share. So related to diabetes, of course, the most important figure we always tend to pass it here, and that makes things a bit easier, is the mechanism of insulin secretion. As we have seen here, the beta cell, just a cartoon of beta cell, the response of the cell itself when there is too much of glucose and when there is little glucose, okay, and described as resting cell or stimulated cell, okay. When there is too much glucose, it has to be stimulated in order to produce insulin. So a very important channel called potassium ATP channel will stay closed, okay? And that would be secondary to too much of ATP being generated because of the process over here after the uptake of glucose into the cell, and through a very important enzyme termed as glucokinase, there will be generated too much of ATP, and that will allow potassium ATP channel to close. Too much potassium in will stimulate will provide a depolarization of the cell membrane, and that by itself will stimulate a voltage-gated calcium channel, which allow an influx of calcium into the cell, and that by itself will help into the insulin exocytosis. The insulin which had been produced indeed through the endoplasmic reticulum, and a lot of transcription factors are involved here, which will come later in my talk, okay? So the bottom line here, just to remember, too much glucose, we need to stimulate it for, we shall close the KATB, and that will lead to secretion of insulin. Less or minimal or controlled glucose, no need for insulin. So the potassium ATP channel will stay open and allow the potassium to go throughout and maintain a hyperpolarization. For diabetes in general, heterogeneous complex metabolic disorder characterized by chronic symptomatic hyperglycemia in both fasting and postprandial states. Once diabetes being diagnosed, the second question would be, what type of diabetes, okay? The steps in clinical subtyping an individual first diagnosed with diabetes is indeed you go through certain points. If the patient is diabetic but asymptomatic, it will be very important to establish what type of diabetes to then guide you the further steps. You need also to exclude secondary causes of diabetes, consider to divide or to allow you to dig more into the causes. Is the onset of diabetes, the early onset, suggestive of neonatal diabetes? The later is more of probably type 1 diabetes as the commonest we have seen in our pediatric age group. Family history is very important, illustrated as into autoimmunity, first of all, then if there is any type 2 diabetes running in the family, and then if there is any sort of diabetes that is running in family but probably not being picked up or not treated. Physical examination, very important, presence of insulin resistance signs, and also presence of metabolic syndrome. Then subsequently, if there is any ketosis or ketoacidosis or none, and eventually the investigation, which usually being done for beta cell autoantibodies, C-peptide, and that would be really a marker to help us defining the types as well. So we have here type 3 years old, 19 months of age, presented with activity, 2 weeks of polydipsia, very high reflux, severe metabolic acidosis, in keeping with early onset or the DKA with newly diagnosed diabetes, managed in the ICU. Their DKA protocol did really well after all. Initial hemoglobin A1C was 10, then over the period of follow-up, it was coming down. Here, total daily dose still 0.6 units per kg per day. She does have a remarkable positive antibodies, anti-islet cell and anti-GAD, and low level of C-peptide and insulin. So this is pretty clear that most likely a type 1 diabetes. We have daughter here, 12 years, presented with a month history of polyuria, polydipsia, and a remarkable weight loss. However, she is running a high BMI, positive acanthosis nigricans, high blood pressure, positive ketones, but normal blood gas, very high hemoglobin A1C, managed with subcutaneous as initial steps because still not resulted in terms of autoimmune profile, considering her age. And later it showed negative antibodies, high C-peptide level. In our follow-up to her, we shifted her to metformin and basal glargine, and then she did really well with a reduction of glargine as well, along with continuation of metformin. So this is most likely indeed a type 2 diabetes. The third case, which is quoted from the SPAVA, previously healthy female, no past medical history. Upon screening done in school for cholesterol and diabetes, a normal BMI, normal lipid profile. She had the point of care hemoglobin A1C being done for her, which showed a diabetic range. However, she doesn't have symptoms, and there is a strong family history of diabetes. There was no acidosis or even ketones, normal glucose level, but glucose urea, and autoantibodies done for her, discharged home with a plan of endocrine follow-up. I just passed this question, will you treat this patient or not? If my colleague, Dr. Saud, would like to ask the So to cut it short.
Saud, can you put the question, please?
Yes or no?
Somebody said yes.
Okay, that's fine. So he will or she will treat. Okay. Now the team here didn't treat, okay, but did a repeated labs and autoantibodies. The repeated hemoglobin A1C is actually raised. The autoantibody screen came back negative, okay? And the child still is symptomatic. They have done OGTT, which showed a basal or a 0-hour glucose normal, a 2 hours glucose is high in the range of diabetes, okay? There was a strong family history of diabetes running in the family with autosomal dominant manner involving females and males and not skipping any generation. So this is an autosomal dominant pattern, okay? So they have done the genetic testing for this girl in keeping with negative antibodies, young age, normal BMI, no sign of insulin resistance, and a diabetic range anyway, okay? So it did show a form of MODY, HNF4A, and the patient remained okay with a good glycemic control, but not with insulin, with glipizide. And this is really very important and remarkable for her, because if we haven't done the genetic testing at this point of time, with the diabetic range of hemoglobin A1C, although asymptomatic, one could argue we should have started insulin for her, okay? And comparing or balancing the effect or the benefit of insulin and the risk of hypoglycemia with all other stuff related to the needle issues and the tremendous, the monitoring and all, genetic testing for her did provide a benefit and a remarkable benefit to her, okay? Very important thing to highlight today is basically the new classification of diabetes. It's not much changed a lot compared to the previous classification of diabetes. However, this time, probably in terms of defining it more centered into the beta cell. So beta cell centric model recognize dysfunctional beta cell as the common denominator of diabetes. And this is used as monogenic or polygenic, okay? The advancement, what we have seen now for the last years in the genetic diagnosis did help a lot in all medicine. And as far as MODY is concerned, is actually help us in understanding more of those subclasses, right? And that, of course, will help into tailoring the treatment of the patients based on their types, and that would help into the outcome in the future. So the classification system here showed, in general, we have the commonest type, type 1, and then type 2, the hybrid form, other specific types, including the monogenic diabetes, which I will concentrate today, unclassified, and hyperglycemia during pregnancy. The monogenic diabetes being further classified into monogenic defect of beta cell function, defect in insulin action, and other genetic syndromes associated with diabetes. For the monogenic defects of beta cell function, which I will concentrate here, is basically defined into MODY and neonatal diabetes, either associated or not with the with well-known syndromes. So monogenic diabetes being classified based on the defect that is happening in any or in the most very well important steps within the beta cell, within the beta cell itself. So either it's a transcriptional regulation disorders or enzyme disorders, protein misfolding, ion channel disorders, or signal transduction disorders. And those are the well-recognized types or classes or subclasses, you name it, being named in the classification started with the mutated gene and then followed by clinical syndrome. The black four top here showed the most common types of MODY, and the subsequent ones here, it's that one illustrating the neonatal diabetes. Okay, so for MODY, which is maturity onset diabetes of the young, inherited disorder for non-autoimmune diabetes mellitus, antibody negative at a younger age. It's been described since 1974 with a mild familial diabetes with dominant inheritance. And there has been a very good or very heavy work being done by so many countries in trying to estimate the prevalence of MODY. So it's ranging between somehow 0.24% to probably 2.5 to maybe 3%, right? Some countries we don't have actually the prevalence of MODY not yet known, and that might be basically poor referral rate, or also the availability of genetic service and how being easy to set for the genetic testing in the country itself or in the particular areas, right? There is an important notice also that around 80% of MODY cases in the UK are thought to be misdiagnosed as either type 1 diabetes or type 2 diabetes. And this is really important, likewise, anywhere else. So we might still see patients whom we consider it's type 1 diabetes, managed similarly with insulin injection, stable and good glycemic control, but might be actually one form of MODY. Not necessarily we are doing all genetic, not necessarily we have the, refer every patient to know the exact genetic testing, but we will have to tailor some certain patients based on the clinical findings. So when to suspect MODY, the updated diagnostic criteria if the onset is before 25 years, presence of antibodies, diabetes in 2 consecutive generations, absence of beta cell autoantibodies, and sustained endogenous insulin secretion, preserved beta cell function, and that can be illustrated by a prolonged honeymoon period or actually a lack of insulin treatment beyond the period which is thought to be a honeymoon period, and a good level of C-peptide above 200 picomole per liter after 3 years of insulin treatment. That would really support the request or support the need for a genetic testing for these particular patients. MODY can be distinguished from type 1 with absence of, just to make it like clear or easy to know, absence of islet cell autoantibodies, and from type 2, absence of feature of insulin resistance. Now, there are lots of genes, but the commonest forms are the first 4. Around the most common one is HNF1 alpha MODY, and this is based on a European study. Actually, this is illustrating the prevalence of MODY types in some European countries. Then the glucokinase MODY, after that HNF4 alpha MODY, and so on. So a few words about each of, I hope I'm not, a few words about each type. For glucokinase MODY, which is quite, what we can say, really important to know to diagnose those patients, because actually they don't require treatment indeed. So they run a fasting mild hyperglycemia, which is stable over a period of months and years. So they don't have the potential to develop that overt symptoms, okay? And then here their hemoglobin A1C is stable. When we do OGTT on those category of patients, they don't have this increment of the 2 hours postprandial, and there might be a history in the family going on about diabetes. They don't rarely develop microvascular complications. So basically, they don't need a form of treatment. So mainly diet control. This is glucokinase MODY, where the defect is actually in the enzyme converting the glucose to glucose 6-phosphate. For the HNF1 alpha MODY, it is the commonest type. They could start with glucosuria with normal blood glucose. The OGTT have a larger increment compared to the glucokinase MODY, and there will be a family history of diabetes. Progressive, and it could lead to symptoms as well. This category of patients, they are actually could be at our setting now in our clinics, be treated with insulin as a type 1 diabetes. They do have also a risk of microvascular and macrovascular complication. But the beauty of this type is that if defined or diagnosed, they are really sensitive to sulfonylurea. So instead of having insulin injections, they could simply be treated with oral hypoglycemic agents. And this is when we are saying this is an example of personalized medicine, whereby genetic testing, you are able now to direct certain medication or treatment for certain patients, not for the others. And of course, saying for the patient, you no longer need insulin, no longer required injections or these intensive monitoring. This is really one of the things that they really dream of. Like an example of every type 1 diabetes dream of such a conclusion or such accomplishment. The HNF1 for alpha MODY behaving like HNF1 alpha MODY. However, these have also an interesting identity. If the patient is carrying this mutated transcription factor, in the early stage of life, in the infancy or postborn, they could behave like a hyperinsulinemic hypoglycemia, but that is really transient, okay? And later, they could develop diabetes in life, okay? So knowing also this type will kind of predict or anticipate the future of these patients, so for more closer observation and follow-up, okay? Right, so that was mainly the three commonest forms of MODY. I didn't go into other details. I thought it might be really very concentrated or high dose of detailed genetic specifications. Very important comments about neonatal diabetes mellitus, about 2 slides here. It's a very special identity of diabetes mellitus. It occurs first 6 months of life. It could be a transient or permanent. The transient could resolve indeed, and quite good proportion of them having actually abnormality in the chromosome 6q24 region, with which will predispose those category of patients to develop the diabetes. However, it will resolve by itself, right? We have, as I mentioned, some transient neonatal diabetes resolved later, but may also relapse. Permanent category is secondary to mutation in the potassium ATP channel, which we talked about earlier. That is important into maintaining the required depolarization of the cell membrane. Okay, so if you have a mutated gene of KCNJ11 or ABCC8, that subsequently lead to a diabetes, and mostly it's like most individuals have actually permanent. However, those category doesn't require insulin. They respond really very well with high dose of sulfonylurea. Okay, so some also other types will have a pancreatic exocrine failure and developmental delay. Immediate molecular genetic testing is important to define their subtype of monogenic neonatal diabetes mellitus to help us then, if we have these mutated genes in KCNJ11 or ABCC8, then that would be a candidate for a trial of sulfonylurea and not for insulin. So that really would also personalize the management of those patients depends based on the genetic background or genetic problems. So the action of sulfonylurea, one of forms of glibenclamide, is actually a closure, maintaining a closure of K-ATP channel. And as we said, when we close it is basically led to maintaining a higher concentration of potassium inside the cell, more depolarization, efflux of calcium through the calcium channel, which is voltage gated, and that will allow more insulin to be excreted. So this is a summary of the of Moody genes in general. Those are the top commonest, and those are really very rare, but well described, and more important that some of those types are actually sensitive to sulfonylurea, where we could swap or shift the patient from insulin to sulfonylurea. So this is a simple approach. Patient with diabetes diagnosed before 25 years of age. If diagnosed before 6 months, then mandatory to do genetic testing, because it might be a permanent neonatal diabetes as well. If there is abrupt onset with ketosis, slim, insulin deficiency, yes, then you will do the autoantibodies. If positive antibodies, then this is likely to be type 1 diabetes. If no, negative antibodies, and again, young, you could actually further clarify it or refine it by doing a genetic testing. If the patient is obese, evidence of insulin resistance, negative autoantibodies, then this is likely to be type 2 diabetes. So this is really a simple, straightforward diagram, right? There's something that I could share with you is basically Exeter in the UK, which is one of the centers where actually did a very tremendous work into monogenic diabetes, a lot of work into the neonatal diabetes. And actually, it's like the center of doing most of the gene testing for all countries by free of charge for particular monogenic diabetes, have done MODY probability calculator, which is actually done based on their population. But we could just like, you know, have it and try it with some clues from the patient. If you're really in doubt that this is not a straightforward type 1 diabetes, neither a straightforward type 2 diabetes, and that might give you some probability where you could justify the potential of having MODY, and then you could then push or insist or refer for a genetic testing accordingly. So I have a patient here with me at the moment, in my clinic, I mean, who is 8 years. He was, have seen him since age of 5 years, normal BMI. He does have a slightly raised fasting level. A C-peptide is also detectable. Anti-islet cell antibodies is negative. Anti-GAD antibodies is also negative. And his hemoglobin A1C is initially 7. I had a discussion with my colleagues whether to treat or not to treat. We ought to, because he was asymptomatic also, with a close follow-up. Parents did some diet manipulation as well to reduce the carb in a way, right? So repeated glycated hemoglobin 6.2%. At the moment, not on insulin. However, I haven't seen him for quite some time. just reviewing now for the presentation, he just came in my mind, and retrieving his data. I applied his numbers or his clinical information, and indeed it actually gave me really a high probability that this might be a MOD, or I could, the planning for MOD testing was actually being enlightened or proposed for parents initially, but they have actually lost follow-up. So probably just recontacting them and proceed for that. So what I'm trying to say, it's just like a helpful tool also to have it in the clinic setting. Okay, so the take-home message: monogenic diabetes is an early example of personalized medicine. Okay, whereby having those information would actually tailor the outcome and management plan for patients, and it means a lot to them. For MODY, we consider with a normal weight, age less than 25 years, negative antibody C-peptide above 200, low or no insulin requirement, you should suspect MODY. HNF1A and HNF4 alpha, MODY, respond to sulfonylurea. Glucokinase, no need for treatment. And for the neonatal diabetes onset less than 6 months, must do genetic testing, and KATB gene mutation respond really nicely with a high dose of sulfonylurea. With that, I would like to thank you for your patience and attention. Thank you very much.
Thank
so
you
any
very
question?
much.
Yeah, sorry.
Thank you very much, Lalila, for this is very clear and in-depth presentation. And actually, too many information for me, actually. And I learned a lot during your presentation. And just now, we would like to ask our attendees, if they have any question, they can put it in Q&A, or they can raise their hand, actually. And then Saud can also open for them the mic instead of typing. I know some people, they don't like type, they want to express their questions. And let me take the first question from Haidar. Is absent antibody exclude type 1 diabetes?
Very, very good question. Now, what is the antibodies? Again, a discussion. So we have the most common antibodies are 4 of them. In my setting, for example, I do the 2 of them, which is anti-GAD and anti-islets. So if we are able to exclude all, then yeah, likely to be not a type 1 diabetes. But not necessarily that we are able to do the 4. If the anti-GAD and anti-islet is negative, and there is other clues that puts this patient as not a straightforward type 1 diabetes, then yeah, it could be a MODY. But not every clinic is doing actually the 4. So we just need to be careful with this.
Okay, excellent. Do you mind to go to one of the slides where you showed the different of genetic mutation?
Yeah, sure.
It's fast today. So until Dr. Thamar still not with us. So if you can follow up, if you can follow up with Dr. Thamar till he with us, then just one slide there. So will you give her again the ability to share the slide? So
we have here, or you may, which one you like? Okay.
It didn't share. So just click on the share. Sorry.
وين أنا اختفيت لحظة؟
إذا في مشكلة خلاص كنت لابس أريج. I want to see that one with a different mutation and different treatment.
Dr. Ahmed, there are somebody raise hand.
Okay, so let's take question.
Dr.
Okay.
Maymoon Al-Qanoubi.
Okay. No, let me go back please to that slide. Go up. So
this one, Dr. Ahmed, or
this is the one. So
this is kind of summary indeed for most. This is kind of summary.
So is there a big difference in the treatment compared to the different genetics mutation? I can see most of them, they need oral or they need treatment. So almost all of them, they need treatment, unless some of them can be managed with diet control, isn't it?
So we will just need really to be careful, because those in this category is basically really rare.
Okay.
And those in the top are the most common forms of MODY in general.
Mm-hmm.
And MODY itself, it's rare, okay? So probably the implication which we sort of entertained with and advertised for is for those areas where they behave like type 1 diabetes, for example, but yet they are okay with that without insulin, right? Personally, I don't have really like patients to then like see the natural history of in real, but some of them do well at, in particular for those rare forms. Probably they do particularly well into oral hypoglycemic agents, or maybe they are in a way that they will need insulin. So kind of spectrum. And one thing that we could highlight for MODY itself, it's not like because of the gene, one certain gene would have a fixed picture or manifestation. It's a really, and that's why it's challenging indeed, because it's a spectrum of symptoms. So they might do well with oral hypoglycemic agent, but maybe in particular for that might be sort of the extreme, they might require to insulin. But I don't have really a personal experience in particular. For the top three ones, they do have really a very strong clinical implication that is very remarkable and very, making really difference for patients, where because they are sensitive to sulfonylurea, you could like substitute the insulin with that, right? But this is not to say now from the take-home message that there is outside there lots of patients, if we do genetic, we then remove the insulin and substitute that with oral pills. This is not the conclusion, but this is sort of maybe the beauty of having advancement in the molecular genetic that will allow us more understanding into the pathophysiology and allow us again to refine the particular treatment for particular diseases.
Let's take Dr. Maymoon Al-Qanoubi. She has a question. Saud, please open the mic. Dr. Maymoon, please go ahead.
Good evening. Thank you very much, Leila, for the informative presentation. I would like to share a fresh case with me who was admitted last night, just to share thoughts about this patient. So this was admitted only last night, 12-year-old boy with hyperglycemia, denied any history of symptoms of hyperglycemia, only dry throat for 1 day. And he was admitted with blood sugar initially was 20, with only trace ketone and no acidosis. So he was admitted for observation and blood glucose profile. His blood sugar came gradually down from 20 down to 10 in the morning as fasting blood sugar 10. Subsequently, it raised up again postprandial to 16. Anyway, to share this patient, I have sent all like the workup for diabetes. He has a sister who is now 18-year-old, was diagnosed with diabetes at the age of 12 years, similar to him. At that time, his sister presented with severe DKA and she was even comatose, required PICU admission, and now she's under follow-up in SKU. What is interesting about this patient is that his sister is on very small doses of insulin. She has frequent hypoglycemia. She has very tight control with A1C, most of the time 6%. And as per father, he said there might be a plan to shift her to oral medication. Not yet shifted, but So for this patient, I highly suspect he can be a type of MODY, especially symptoms are not like for long duration. And I admitted him for observation only, but with rising blood sugar, I got the A1C result as 13.5%. So I decided to start insulin, but small dose. For his age, usually we start 1 unit per kg, but I started him on 0.5 unit per kg because I could not leave him with this very high blood sugar and A1C indicating prolonged hyperglycemia as his A1C is high. I'm still like awaiting the other lab, like antibodies. Sahih, regarding his sister, her antibodies were negative, 3 of them, anti-GAD, anti-islet cell, anti-insulin, and she had low insulin, low C-peptide. So she's not, because she had DKA, severe DKA, so she's not having one of the common MODY type, as you mentioned, like HNF types, because they don't cause DKA. It can be type of potassium channel ATP mutation. What do you think, Layla, about this patient?
Thank you. Sorry, you are a pediatrician also, Dr.
I am, yeah, pediatric endocrinologist, yes. In a
Which hospital? Nahaba Hospital.
Yes.
Excellent. Thank you very much for sharing this case.
Yeah, for the body mass index is again in the, I would presume in the lower side, right? Yeah, in the normal. Sorry, Maimuna.
Yeah, he is a thin boy. He's 12. His weight is only 32. Sorry, I'm not sure about his height. I saw him only once in the morning today, so we need to check his height as well to calculate BM. But he's definitely a thin boy.
Yeah. So I do agree with that. Yeah, with this history and family history, there is a thought, but I would agree with you that starting insulin is the right thing we do now. Bending or tracing the rest of autoantibodies screening. Through my search, there is tendency, not commonly, but they could present with DKA. Rarely, even HNF, either alpha.
Yeah, I found a few case reports.
Only rarely, Aywa.
Very rarely.
Very rarely, but they could present with DKA, so that wouldn't, but the commonest common, I feel, and know what we have done is really great. Like you started with the lower dose, of course, closer observation and bending the antibodies, but very low threshold to do genetic testing, looking into the strong family history, and that would be really probably a good illustration for this patient to be moved to an oral glycemic agents.
Thank you very much, Dr. Layla. Thank you, Dr. Amin, for sharing this case. I think we have some more time at the end. If you can please stay with us, because now we have to take Dr. Thamur Al-Isa. Dr. Thamur is a consultant physician and head of Division of Endocrinology and Diabetes and Metabolism in Al Ahmed Hospital. And Dr. Thamur is going to talk to us about Ask the Expert, Trulicity from theory to clinical practice. So Dr. Thamur, thank you for being with us, and the floor is yours.
Assalamu alaikum jameen. Thank you, Dr. Ahmed, and all the audience for inviting me, and also for Eli Lilly for their counter introduction. If possible, I can share my slides, if possible, for the technical team. Is that possible for me to do it?
They are already on.
Yeah, but I would like to use my own slides if you don't.
So not your own slide. Oh, okay. So your assistant. Okay, so I think you can do so. So because giving this authority to all panelists to share the slide.
So if they can allow me to use my own slides.
Okay, so Shihab, can you stop sharing if you are sharing from your side? Okay.
Okay, so thank you so much. I got it right now. Okay, so let's see, where is the PowerPoint? Excellent. Okay, thank you so much. So I'll talk today about the liraglutide, which is one of the GLP-1 receptor agonists, and see how much it's its clinical effect and practice been using worldwide and also here in Kuwait for the last several years. This is my disclosure. So we definitely have some important challenges when we're facing diabetes management, because we have a lot of patients who are still uncontrolled. This is an average HbA1c in many countries around the world, whether in type 1 diabetes or type 2 diabetes, including also Middle East. This data was old, more than probably 10 years ago so far, but I don't think that's a big difference what we see right now. And depends also the location, how the management of diabetes is done, what is the settings, are you talking about secondary, primary, tertiary centers, that's all makes differences. But what we share with other countries around the world is that we still have a lot of population from our side that we're not really well controlled with an average HbA1c to be above the target rate. So one of the important things we do for type 2 diabetes specifically is advanced therapy. And when we do advanced therapy, we're not only talking about adding multiple oral therapies, but actually reaching the point when we want to convince patients that we want to start using injectable therapies. So it's very important when we want to start injectable therapy is try to find the appropriate time. You don't want to do it too late, and maybe you don't want to do it too soon because you don't want to overwhelm the patient with further therapies that maybe he cannot really tolerate or need. So the decision to start injectable therapy can be made in case of suboptimal control with one or more oral anti-diabetic medications that is not really was controlling their diabetes throughout the previous time. And what it seems from clinical practice, it seems that a lot of physicians delay the intensification of therapy, even giving additional oral therapies. This is data from 2013, 2016 in the UK. They looked at how many years it took them or took a patient to go from one therapy to additional therapy from the time when his HbA1c was not controlled. They saw that going from one oral to second oral, it took patients about 1.5 to 3 years until they take another oral. And it took them about almost 7 years to go from 2 orals to a third oral therapy. And it took them about the same time, about 7 years, from 3 orals to the first injectable therapy, which has traditionally been for a long period of time was the insulin or basal insulin. And it took them about almost 3.5 years until further intensification of injections was started, whether adding a GLP-1, premixed insulin, or even bolus insulin therapy. So it seems like there's a lot of patients who are missing the chance of getting the right control at the right time and not advancing the therapy. So if we have a patient who's not controlled on oral therapy, what are the injectable options that are available? Well, we have basal insulin, definitely. We have GLP-1 receptor agonists, also been very commonly used in the last several years. Then we have the old generation premixed insulin, and we have something called co-formulation insulin, which is also kind of premixed insulin, but instead of using intermediate basal, they used long-acting basal plus the prandial dosing together in the same injection. There's something new called fixed ratio combination, which is in the same injection or the same pen, there is basal insulin and there is GLP-1. And there is always the classical basal bolus insulin therapy where you give basal and you give bolus with me. So these are the typical types of, or the types that are available for injectable therapies. So when we decide on the choice of what therapy to choose, there are several factors. There is presence of comorbidities. So there are certain comorbidities make you choose one therapy different than the other. The glycemic control, how much A1C you want to control and drop. Contraindications, the BMI, tolerance to therapy. Some of them might have side effects that are not really tolerable. Risk of hypoglycemia, sometimes types of insulin specifically can cause hypoglycemia.
It's nice guidelines, not recommend testing for C-peptide at presentation to differentiate between type 1 diabetes and Moody. What is your opinion?
So, like generally, we do check C-peptide, understand insulin that because sometimes we will be starting and it might be of no use. But for C-peptide, we actually been doing it, and some of the cases might be straightforward where you don't, but who could say later. So we actually emphasize on doing from my practice to do C-peptide, and that probably later on might be a clue. Maybe if like a straightforward, no strong family history, you could argue, but if there is family history, that puts possibility of broaden differential diagnosis, then you might do it. So I really not really very strict or very sharp in whether to do it or not to do it, but it's really a helpful tool to start with.
Okay, the other question, what is the dose of sulfonylureas to start with, and how can we transform from insulin to sulfonylureas? Stop insulin first, then start, or overlap both initially?
Here, if I have my friends, my colleagues, if they could actually share their experience in Royal or SQH, because I haven't done it myself. There are reported dosage, but if they would like to share their experience in sort of overlapping and dosage wise, my colleagues, if they are around,
we have
Dr. Hanan, Dr. Musa, if they are willing, like.
Dr. Can you open Dr. Wafiq? I don't know, he wants to comment or he wants to answer this one. I respond to you. So Saud, can you open to Dr. Wafiq? Saud, are you with us?
Dr. Wafiq, please unmute your mic.
So generally, it's starting a lower dose. You could then go up to 1 milligram per kg per day. The overlap has been reported here, very important. And again, it's not sort of with a definitive genetic testing, knowing that this is responding really well with sulfonylurea, a very careful, gradual overlap between the two. So this practice or this exercise has to be done really under specialty care. So I would recommend it to be really referred to a center where endocrinologist could advise and plan on.
Dr. Maimouna, you want to respond because you raised your hand, or it's okay?
I didn't raise, but I know the transition for neonatal diabetes. I'm not sure about older children if we are planning to change to sulfonylurea. But for neonates, as Layla mentioned, yes, we start with small dose. We start with 0.1 milligram per kg per day, and we raise it up to 1 milligram per kg in 2 divided doses. And initially, we have the insulin dose. And accordingly, like if we reach the maximum dose and we find response, so we know that this patient is sulfonylurea responsive or not. But older children, I'm not sure, but we need to review it. Probably similar way of over a period of overlap, and according to response, we increase the dose.
Which one of the sulfonylureas usually use?
Glibenclamide, gliclazide also can be used.
Excellent. Thank you very much. Thank you. So I think we covered all the questions. I don't see anything remaining. So thank you very much. Thank you very much, Dr. Layla, for being with us tonight. Thank you very much, Dr. Thamar, also for your talk. And thank for all participants for being with us today. So it was an excellent meeting. And please stay tuned to ODA social media and to see you in next Lasave 9 for a new topic. Also, we would like to express again our thanking to Lily for sponsoring this event. So thank you very much, everybody, and have a good night and see you next time. Assalam.